So good evening, everyone. My name's Dan Winter, and I am a Research and Education Officer at the University of Sydney Specialty of Addiction Medicine. And I'm here today to introduce or provide introductions for the Sydney Addiction Seminar. As many of you would have seen, the topic today that we are discussing is the New South Wales Alcohol Interlock Program, as well as looking at fitness to drive medical assessments. And we have two wonderful facilitators here joining us today, including Professor Kate Conigrave, who is also based at the University of Sydney with myself, and at Drug Health Services in SLHD. And we also have Dr. Craig Sadler from Calvary Mater Newcastle within the Hunter New England Drug and Alcohol Clinical Services team, who has kindly stepped in for one of our other presenters who could no longer make it, which was Paul Haber. Before I do get started, I would also just like to, of course, include the, let everyone know that, of course, the Sydney Addiction Seminars are sponsored, in this case this year again, as of last year as well. Indivior has kindly agreed to sponsor the seminars, and we're very thankful for that contribution from Indivior. However, I'd like to emphasise the topics are still solely chosen by the seminar conveners and their teams solely, and the contributions will go towards paying a small honoraria to the facilitators for the day. Before I do go any further, though, I would like to make an acknowledgement of country. So wherever we are this evening, I would like to acknowledge the traditional custodians of the country on the lands on which we are all meeting, and recognise their continuing connection to land, waters, and culture. I'd like to pay our respects to elders past, present, and emerging, wherever you're based this evening. This evening I am based on Gadigal land, the people of the Eora Nation, and I ask you to all please extend that respect and acknowledgement to all the lands on which we are based today. Just very briefly, before I hand over to our convener for this evening, which is Dr. Richard Hallinan, who I forgot to introduce just before, I thought it would be good once again to show who's registered for tonight, just so we get a rough idea of who's here this evening. Obviously, everyone who's registered may not actually attend, but we have about 69% people who are based in metropolitan sort of LHD areas, if you would think of it that way, and about 25% based regionally. We also do have a few interstate colleagues, so very happy to have interstate representation as well. Wherever you join us this evening, welcome. And in terms of the registrations, in terms of role or specialty, if you'd like to think of it that way, we've got a fair good makeup of GPs and addiction medicine roles, including specialists and registrars, a few psychiatrists as well. We also have some wonderful representation from people in nursing roles as well, which include nurse practitioners, CNC roles, RN roles, and so forth. And we also have various other health professionals, including pharmacists and the like. But that is all for me now, and I'm going to hand over to Richard, who will. Richard, do you have any thoughts before we hand over to Kate?
No, I'll just introduce Kate, if that's all right. So everybody here probably knows Kate Conigrave, professor, as in conjoint professor with the University of Sydney, and an addiction medicine specialist, but originally a public health physician, and as well as having a substantial clinical role still at RPA Hospital, Kate is enormously productive in terms of research and so on. Particularly treating individuals with problems of alcohol and promoting the health of communities and with a special emphasis on Indigenous health and alcohol. And if Kate has presented for us twice in the past, I just saw into the archives almost 20 years ago, 2004, on one of the major topics, alcohol, anti-craving drugs. And in 2014, 10 years later, with Michael Doyle on Aboriginal and Torres Strait Islanders and substance use problems, as a result of which I have this excellent book, which was recommended at the time. I don't know if you can see it. The title there, Richard Broom's really helpful tome on Aboriginal Australians with some remarkable history in there. And I found my bookmark, so I got up to page 277 back then. So Kate's going to talk to us about the Alcohol Interlock program, which will lead nicely into Craig Sadler's presentation in the second half on fitness to drive medical assessment. Now, Dan, should we just mention about the chat? I'm not actually seeing it here, but I can't seem to get it up. Can you keep an eye on it, and maybe just if there are questions being asked there, let us know. Over to you, Kate. Kate, I think you're still on mute.
Right, thank you. Thank you very much.
Kate, I had to also mention that Kate is an accomplished violinist.
Once was, not as good as Richard, I think. So thank you very much for having me. So it's interesting, once every 10 years. And I see some familiar names and some familiar faces, so lovely to see you all. And just to acknowledge, I'm sitting on Wallamadigal land, which is between the Parramatta and the Lane Cove River in part of the Eora Nation. So acknowledging elders past and present and all my wonderful Aboriginal colleagues. So let me share slides if I can. Hopefully you can see that. This was a real trip down memory lane, because I've had virtually nothing to do with the Alcohol Interlock program since I was asked in about 2014 to help develop the medical aspects of this program, the materials for GPs. So I had, so anyone who'd like to send me letter bombs, I had nothing to do with setting up the program itself, just advising on the medical aspects of it. And I understand that the Transport for New South Wales is currently looking at reviewing the program. Two people from Transport New South Wales were thinking of attending to tonight. I can't see if they're here or not, but if so, I do hope they'll throw into the conversation and correct me if I'm wrong. So just a bit by way of history, the Alcohol Interlock program followed on a predecessor, which was the driver assessment program, and several of the major hospitals around Sydney used to operate driver assessment clinics as part of that. And I was involved in seeing some of the clients at the RPA driver assessment program clinic. And after month would go by in that pilot, and nearly every single patient that you were assessing would say, oh, that was a one-off, that drinking and driving. I don't normally do that. You know, the relationship broke up or some other disaster happened or I lost my job. I don't normally drink and drive. And at the time, there weren't the full range of biological markers that we have available today. CDT was just starting and not broadly available. And I think many of us who were doing the assessments decided it really didn't seem to be achieving very much. And at the same time, Transport for New South Wales was looking at interlocks. So maybe from that, we'll just talk a bit about interlocks, if my slides will advance. It's interesting. There we go. So there's a picture of an interlock being used by a driver. And many of you will know it's basically a breathalyzer that's linked into the ignition of the car. So if the person blows positive, which from practical purposes, I gather is normally 0.02 or above, then the car won't start. There are fancy additions, like you can have ones that require you to hum so that you can recognize the voice and know it's the right person blowing it, or you can have a camera to show it's the right person using it. But the basic one is pretty much as you see. And there's a close-up of one particular model. So you have to have a blood alcohol of pretty close to zero, typically under 0.02 for the car to start. And it also regularly asks you to retest. It beeps at you and tells you to pull over and retest. And if you don't do so within a certain space of time, my understanding is the car will slowly grind to a halt. Every 2 months, you've got to go back and get the data downloaded from your interlock. And then from that, it's transport for New South Wales, and you'll see why it goes to them shortly. By the way, I'm just getting a notice saying my internet connection's unstable. Text me if I stop showing up and I'll turn my video off. So we've talked about that. Okay, so do they work? This is a 2004 Cochrane review, and it showed that they can stop repeat drink driving offences, but only as long as they're fitted. There's some evidence you might get a slight reduction in drink driving in the months after it comes off, but I gather that in most studies that's not significant. So in New South Wales, the program came in 2015 with the goal of reducing future instances of drink driving. So who has to get an interlock? It can be court ordered, and typically it's court ordered for a medium or high range drink drive offence. So medium being, I've said over 0.08. I can't remember if it's greater than or equal to, but it's about 0.8. Or also for a repeat drink driving offence, or also if you refuse a breathalyzer test, because then it's assumed that you've got something to hide. So it's court ordered, and it has some advantages for the user because it can shorten a lengthy disqualification period. So for example, if you're a high range drink drive offender, so you've got a blood alcohol of 0.15 and above, you might have otherwise a 5-year disqualification period. With an interlock, your lawyer can ask for a shorter disqualification period, and you can drive with an interlock, which can mean keeping your job if you rely on the car to be able to get to work or to be able to do your job. So how have they gone in New South Wales? Last year, a paper came out from Boxar looking at the data, and they found an 86% reduction in recidivism for high-range offenders compared with people with slightly lower blood alcohols and no interlock. So certainly they seem very good at stopping people drink driving while they're installed. The beauty of that is for the doctors and the other people involved with the patient is you actually don't have to worry as a doctor about are they going to drink and drive, because it's almost impossible for them to drink and drive. Obviously, they can drive someone else's car, but if they get caught doing that, they really get, the book thrown at them. So there's a lot of upsides for the client and there's a lot of upsides for the public, but there are also downsides. They are not cheap. They cost around $2,000 a year. And that includes the installation, the leasing fee, and that second monthly data download, and also the removal of it at the end of the time. There is a 35% discount, I gather, through installers if you're on a healthcare card. And there is a scheme for severe financial hardship, which is operated through the salvos. There are 4 accredited installers in New South Wales. So if you're in Sydney, you're okay. And, they're sprinkled around regional areas. But when I had a quick look, there's one at Parkes and an Orange in central Western New South Wales. But if you're at Broken Hill, you may, as far as I could tell, you'd probably have to drive into one of those centres, which is a bit of a trek, especially if it's every 2 months. And on top of that, you've also got your licensing admin fee through roads and traffic. So what's involved if you get a court order that says you have to get an interlock? What happens? Typically, the interlock's not instead of a fine, that you'll typically get your fine and you'll get your disqualification. But as I mentioned, the disqualification can be shortened if you're going on an interlock. Before you can get the interlock, you have to see a GP. Now, the reason it was set up this way was to get around this issue that before you're going to a special clinic to a doctor you typically never saw again, and you could tell them anything. The idea was this would be purely a therapeutic appointment, that you'd be getting screened by a GP. Hopefully the GP will be able to engage you a bit in a discussion on your drinking and offer you treatment if needed. And the GP doesn't have to send a report on your drinking to the roads and traffic people. And also because of that, it can be claimable under Medicare because it is for a therapeutic purpose. So it's very different from a driver assessment appointment. So this GP consult for enrolment in the Interlock program, it's typically billed under Medicare Level C, and the drink less kit is suggested to guide the consult. Some of you may have seen it, but others may not. Drink less kit was developed by a group led by John Saunders way back in about the 90s, based on a World Health Organization brief intervention. So when you, as a GP, doing this assessment, the roads and traffic site links you to the addiction medicine site at Sydney Uni. And I've got this up to show that when the link was first there, it was just the drink less program. Now it's a bit harder to find, and it's right down the bottom where that arrow is. Oops. Oops, sorry, I've just mucked up my screen sharing. I'll get it going again, excuse me. Okay, I was trying to move the toolbar off my screen out of the way. Okay, so then the person fills in the audit questionnaire, and some of you may know this. It's a 10-item, again, World Health Organization questionnaire. The first 3 questions are the consumption questions, also known as Audit C, which are your very basic. How often do you have a drink? How many drinks on a day when you're drinking? And then the third one, how often do you have 6 or more standard drinks on one occasion? So that you're trying to catch people who have an episodic drinking pattern. So maybe during the week, they only have 1 beer after work, but on Saturday night, they might get plastered. Then the next 3 questions are about features of dependence, not being able to stop drinking once you started, not being able to do what's normally expected of you because of your drinking, and needing a morning drink to get started. And then the final 4 questions are about harms that might be associated with your drinking or concerns, guilt or remorse after drinking, being unable to remember what happened the night before, if you've been drinking, and having someone, you or someone else, injured, or having a friend, relative, doctor or health worker concerned about your drinking or suggesting you cut down. So there are 10 questions. It's a very well validated screening tool as an early measure, but also it can be used to screen for an alcohol use disorder. So there's a scoring template that comes with that kit and shows you that for each of the items, you go from 0 to 4. And the bottom 3 items is just 0, 2, and 4. And if we zoom in on that top bit, it's showing that if you're 0 to 7, you're low risk, and that's what you can do. If you're 8 to 12, it's at risk, and you can do a brief intervention using the FLAGS acronym. And if it's 13 or more, it's high risk of dependence. And you can assess dependence and assess any withdrawal symptoms, and you might want to do a physical exam and blood test. So as you can see, it's like following a cookbook. Even if a GP is not confident on alcohol, everything's laid out in front of them, pretty much. And then there's a handy card to lead them through the brief intervention. So there, if someone's low risk, those are the benefits they might get out of it. But even at low risk, there can be some risks. If they're at risk, 8 to 12, as you can see, it's almost like it's trying to do motivational interviewing, but on a card, on a tip sheet to help the doctor. So, you know, the benefits, if you're being honest, you might mention they enjoy it and they get something out of it, but they can get common problems like poor sleep and feeling down or whatever, and risk of injury. And then for the high risk, again, here it's not showing you the benefits, but the client knows the benefits, and you can have any of those harms above, plus obviously more risk of damage to the organs and of physical dependence. It goes on to sort of do a normative comparison. So where do you fit? So if you're at risk, showing you that, you know, only some 20% of the population's at risk, though 5% have more severe. These are just rough figures, and these are now probably 10 years old, but, you know, it's not badly out. You know, the at risk is still around probably 25%. And indeed, there are people who don't drink. And then it asks the person, have you thought about changing your drinking? And encourages the doctor to run through the benefits you can get from cutting down, including common things and immediate benefits like sleeping better, losing weight, no hangovers, etc., more money. And some practical steps for how they can do it. So these, of course, are the 2009 guidelines, and all of you are itching to say those aren't the current guidelines, which you all know. Too hard for me to ask for a display of hands, but I wonder, does anyone know the 2020 guidelines? But they're not much different. The per occasion guidelines exactly the same. This one, it's slightly lower. It's a bit under 2 standard drinks a day. It's a max of 10 per week. I think the French sum it up really well. Their guidelines are much the same. They say no more than 2 drinks a day and not every day. And of course, for some situations, you need lower limits, like when you're driving. And if you're pregnant or breastfeeding, you're drinking nothing. And if you're alcohol dependent, or if you've got physical damage from alcohol, you're best to drink nothing. So very dead easy. And it suggests some strategies to cut down. It works best if the person comes up with strategies and they can point to what might work for them or what else they can come up with. But if not, there's plenty there where you can just suggest 1 or 2. You're clearly not going to read out everything. And they suggest, you know, encouraging the person to see how they're going and come back if they need any help. So all very low key, and it's got the numbers of the specialist advisor. It's got the numbers of ADIS there, I think, for the client. And in the original Drink Less kit, there's these nifty little self-help booklets, which are about fit in the size of the palm of your hand, even in a small hand. I think on the online version of Sydney Uni, the booklets weren't there, but you could actually still see them on the Sydney Local Health District site. So that's the Drink Less kit, and there's another version of it available called the Alcohol Awareness Kit, which we made originally in collaboration with a number of our Aboriginal colleagues, including Bradley Freeburn at the Aboriginal Medical Service Redfern, and with our colleagues at ADAN, which is now called ACDAN, the Aboriginal Corporation Drug and Alcohol Network. And I haven't put all of them on the slides, so I don't want to give you overload, but they're quite nice and visual. And again, the idea is you don't go through everything. You just go through 1 or 2 things that might be relevant to that person, and they can pick out things that are relevant. And I know some of our nurses at RPA, when they're doing consultation liaison work in the ED or on the wards, they sometimes use this resource, not just for Aboriginal clients, but for people where English is a second language or from another culture, that it could cut across some barriers. And it has all those steps, or most of those steps that the Drink Less package has, this resource has too. If people are interested, I've got the slides on another set. I can show them. They're all available for free download from the Sydney Uni Addiction Medicine site. All right, so coming back, you've seen what the resources are. So this is what the GP is encouraged to use. So remember, we said that the GP doesn't have to report back on the drinking, so it means the patient can be upfront and open with them, or are more likely to be able to be. All the GP has to say is that this patient was seen by me and underwent a consultation to discuss alcohol consumption. That's the only thing you have to send back to the RTA. Oops, sorry, I've gone backwards. We'll try again. Now, for people who go on the alcohol interlock and they don't try and drink and drive while they're on the interlock, so all their readings come back at those second monthly downloads that they're being well behaved and managing to separate their drinking and their driving, or to stop drinking, whichever they've done, they don't have to come back and see the GP before they get their license back, because they've had their punishment, they've had their disqualification, they've had their interlock. They get a fresh chance. But some patients, if they haven't gone as smoothly, do have to come back for additional consults. So a person may be asked to come back and see a GP during the program if they're repeatedly trying to drink and drive, as shown up by those data downloads. It's not mandatory. And again, the sole purpose is therapeutic. And again, the doctor only has to fill in a certificate to say they've come. On the other hand, at the end of the program, if someone's continued to have drink drive attempts in the last 6 months of the program, then they have to have a mandatory end of program assessment. And that one isn't just therapeutic. That one is a fitness to drive medical assessment. And so for that one, it's tricky for GPs and it's tricky for patients, because it's not just therapeutic. It's not clear that it can be billed under Medicare. And my understanding is, the advice we had back in 2014, technically it can't. Though, I'm guessing if you do some therapeutic element as well, the therapeutic element can be billed, but not the filling in of the form. So, as sort of promised or threatened, I'm running well ahead of time. But one thing I wanted to leave with you is that I know as doctors doing these medical fitness to drive assessments, they can be really challenging, particularly if you know the client or you empathize with the client and their need to get a car and get back to work. And it can be very tricky. Just a thought that if you get a patient and you really don't think they're safe to go back to driving, you believe their dependence is, they haven't been able to separate the drinking and the driving, and you can't see any sign it's going to be any different when they get their license back, just a reminder that there is an option to recommend a condition on the license. So here you can say meets the medical criteria for conditional license, and then you've got all these standard conditions. Down the bottom is recommended other license conditions. Certainly, I was told in 2014 that you can write down here suitable for that you recommend an ignition interlock. Now, if there's anyone online from Roads and Traffic Authority, it's a great cue for them to come online and tell me if I've got anything wrong or if you have anything you'd like to add. But just wrapping up this bit in the meantime, that the interlock program has a lot of benefits for the client. They can get a shorter disqualification period. They can return to using their car. It has a lot of benefits for public safety with more normal life for the client. And the program does offer this opportunity for therapeutic engagement with the GP. They don't even have to go back to the same GP for the fitness to drive assessment. So they can be open with their GP if they feel safe to. And only persons who repeatedly attempt to drink and drive in the final 6 months of program end up needing a fitness to drive assessment as a result of the interlock program. So that's the end of my formal bit. So I'll stop sharing. And
okay, Richard here. Could you possibly, well, if you could just go back in our minds 2 slides where you showed us where we have the doctor has an option of saying an unconditional, conditional, or no license at all. When or in what situation does the doctor encounter that? Is that when they do a fitness to drive assessment?
Exactly. Yeah. If they're at that final assessment that a person's been required to do because they're still trying to drink and drive in the final 6 months, then they're doing an fitness to drive assessment. So whether it's in this context or any fitness to drive assessment, my understanding is one can suggest that the person should only drive with an ignition interlock on it. But bear in mind, if you're doing that, it's still going to be expensive for them. So you don't put it on lightly just to cover yourself. You only do it if you really think it's needed.
And this will bring us to Craig's presentation shortly. I understand understand that in certain circumstances, a specialist, addiction medicine or addiction psychiatrist, is required to perform the fitness to drive assessment, and Craig can probably clarify that for us when GPs do it. If they ever do it, that I didn't know they could.
Now, I might be leading you astray there, so I'm interested to know too, but...
We have a question from Miriam Jeffries. So Kate, thank you, wonderful work. Is alcohol interlock program, can it be considered a medical device? Does it get approval from TGA or some regulatory body like that?
Very good question. I know that there's only 4 approved installers for New South Wales transport. So I know there's regulatory standards, but it's a great question. Wouldn't that be terrific if you could get it subsidised as a medical device, and you'd save lives, and you'd probably also help some of our clients reduce their drinking or avoid drinking. Yeah,
so we'll probably take that question on notice, see if we can find out the answer for
my understanding, it's not a medically approved advice, but yeah, but I wish it were.
Now, on the Central Coast, some clients are directed to get interlock fitted up to 2 years for a second high-range DUI. That's from Bridget Conway, just a remark, I think, not really a question for you to answer.
Yeah, it's interesting. I was reading that if a person is a high-range drink drive offender, they can get a 5-year disqualification. So it wouldn't surprise me that if to waive that, they had to have a lengthy interlock period.
So Philip Sheehan's just noting that there are 2 types of medicals. There's a normal fitness to drive and then the interlock medical examination. So they're distinct, just reminding everybody. And here's a question, I think, from John Smarter. Is it a comment? Just read it out anyway in case you can't see it. Hi, Kate. Patients often arrive with the expectation that this process is a formality and can be highly resentful when conditions are applied. In addition, the long consult is no longer economically viable if bulk billed under long frozen Medicare rebates. It's not really a question, but...
Yep, I could well imagine it, that even the initial consult, which is purely therapeutic, they don't know that. That for them, it's just a hoop they have to get to, and they can't even get their interlock installed till they've done that first therapeutic medical consult. All you can do is reassure them that it's confidential. You don't have to pass on the information, and you know, that you weren't the one who dreamt it up. Don't give them my name, John.
Now, look, I think we can probably, since we're ahead of time, we can go on to Craig. Kate, will you be staying with us a bit longer?
Yes.
Because we might get to alcohol biomarkers and maybe even some of the newer ones, ethyl glucuronide and phosphatidylethanol as possibilities. As I introduced Craig, you might have seen that I sent out some pre-reading. If you don't have access to the article by Edward Ogden and colleagues, when should the driver with a history of substance misuse, that's their term unfortunately, be allowed to return to the wheel? It was a review of the Osroad guidelines at that time in 2018. If you want a copy of it, just email me and I can share it with you. They remarked that a couple of interesting things, that doctors that you know were more likely to be go easy on you than doctors that you don't know. They also remarked that very few addiction specialists in Australia are willing to perform these medico-legal assessments. They remarked further that there is no particular resource for a psychological or a cognitive assessment which is standardized, for instance, in Germany. So they concluded that requiring a specialist report prior to an application for relicensing was placing an unrealistic and insurmountable hurdle in the driver's path. Now, I might be one of those hurdles because I'm one of those people who's reluctant, at least in the public sector, to do these assessments. They finally also suggested that hair testing would be a good objective way of monitoring the result, which is required to demonstrate sufficient abstinence for a license, and they recommended that Austroads amend the national guidelines to include some of these specifications. Now, they were amended, I think, just last year, and I don't see that any of them were adopted. But this is my opportunity now to introduce Craig Sadler, who's Senior Staff Specialist and the Director of the Withdrawal Unit at the Mater Hospital in Newcastle, and formerly also at Belmont Lakeside. And are you still a visiting medical officer in Western New South Wales?
Yes, I am.
Yeah. So Craig has an extraordinarily broad clinical role, but not only that, his research contributions have spanned a wide range of topics: naltrexone for opiate dependence, the early study on the shortened version of the alcohol withdrawal scale, if you remember that one, Craig, on smoking in hotels, on unsupervised buprenorphine naloxone in a randomized waitlist controlled trial, nabiximols, and QT prolongation. So all of those things going on. But Craig, you were telling me you've done a lot of driving assessments over the years in your public sector position for a couple of reasons. But a lot of doctors in the public sector won't do this, and we might, as we go through this presentation and questions, think about the reasons for that. And I'm hoping your presentation may go some way to alleviating some of the discomfort some of us have in even contemplating those assessments. Craig.
Well, I'm not sure. Yeah, thank you very much, Richard. Thanks everyone for joining, and thanks, Kate, for a great presentation. So a couple of comments from Leon, from Kate. I don't know the answer to whether it's a medical device any more than was already mentioned, the interlock device. But the question you had around the referral to specialists. So on that form that Kate had, where you could request an interlock device under the conditions, you can also request a specialist advice. So from a GP perspective, if you're doing one of those assessments and you really don't know whether their alcohol use is still fulfilling criteria for alcohol use disorder or alcohol dependence, you can complete the form conditional license, but make the recommendation that they have to see a specialist, and then they'll end up coming here. I do note Richard's comments about the study, which I have read years ago, but haven't read it again recently, where seeing a specialist may be a barrier. And hence, that's, I think, why I've been asked to talk about it. Paul asked me to fill in for him. So I don't have the professorial heights of Paul, but hopefully, having seen a lot of patients over the years, I'll be able to do the topic justice. In terms of waylaying people's concerns about doing assessments, I'm going to try and reflect a process that I try to go through, which still means sometimes I have some reticence about, or confusion myself about exactly whether someone is fit or not fit, but I try to follow a process. So I'm going to try and do that overview. So I also got given the brief that I was to, first of all, I'm going to try and share the screen because I'm going to talk about slides now. Is that correct, Daniel?
It looks good.
Yeah, that's the first slide. Okay, so hopefully. So I got asked to comment on that there is an OTAC driving safety course. So I'll mention that briefly because some of the first slides are from that course. It's pretty quick to go through, but it is focused more on opiate treatment and driving. To be able to mention the Austroad guidelines, in case some people were unaware that there is a guideline that covers a range of medical conditions with guidance as to assessing fitness to drive. Then a summary of how I tend to approach the medical assessments, and then a number of cases. So hopefully the cases will create some discussion. Okay. That's moved on, has it? I hope. So Just a couple of quick comments about the driving task. It's actually quite a complicated task. You've got to have sensory input, and you've got to have a brain that processes that sensory input, and then it's got to tell your body what your response is supposed to be, and you've got to have muscle and coordination to do that. So it's not a simple task. What impacts driving safety? Again, I'm sure we're all aware of this, but anything that impairs alertness, including things like tiredness, range of medications, alcohol and drug use, other behaviours, people's experience, their physical and psychological health, and if they've got any cognitive impairment. So they're all quite, each in their own rights, can be quite a complicated little subset. So yeah, I can understand why people are reticent about it. So a couple of just things, these, and as I said, these first slides are from the OTAC driving safety course. So there's a range of medications which are sedating, which we all probably know, and that list is not exhaustive, but they're the major ones, and I guess quite common to see combinations of medications in patients. I'm not going to go through them all. In terms of drug testing, so with respect to driving, there's lab testing, and that's usually either blood or urine. On the road, there's breath or saliva testing, and then if there's a positive at the roadside, my understanding is that then gets retested, either in back at the station or in a ban, a set up ban at the sites of alcohol and drug testing, and the positive results get sent off. That slide says regardless of the result, it's sent for laboratory analysis, and I'm not sure of that. That comes from the driver safety course, so I'm not sure of that. So I'm happy for anyone to dispute that, because I don't know the answer. There are, reports of false negatives and false positives. I've had patients tell me that they haven't smoked cannabis for, several days, and they'll test positive. And I've had patients tell me they've smoked cannabis a couple of hours before driving, and they tested negative. So the mobile drug testing still has some problems associated with it. So we as medical and other health professionals, what have we got to consider? We've got to consider, is the person in front of us fit to drive right now, today? And then the broader question, is the person fit to hold a license for long-term driving? So we've got a care and obligation to advise. So if we've got someone who we think has an illness, an injury, or they're on treatment that may affect driving, then we need to discuss that with them. We need to document it, and we need to try and assist them with alternatives about how to get home. So there I'm talking about people that might present to us intoxicated for appointments, may present to ED, but also broader medical situations where the person may be physically unwell, and you have to make a decision that person can't drive. They broke their leg is a simple example of, well, that person probably can't drive home. But there's far more examples of multiple diseases where doctors and other health professionals have to make those decisions, or at least offer advice. From our perspective, if people are on a medication like methadone or buprenorphine, and there seems to be other prescribers who are prescribing sedative information, then the sharing of that information is important. Even if the patient doesn't give consent, if there's other prescribers treating the same patient, my understanding is you can converse with those prescribers because they're currently involved in the care of the patient. And so we have to decide short and long term, and whether there's a medical condition, or if there is a medical condition, then we would encourage the patient to inform the licensing authority. That's our, for long-term conditions, that's our obligation. We're not obliged in New South Wales to mandatorily report, but I believe it's different in other states. Again, people can jump in and correct me because I don't profess to know all of those finer points. Whilst you don't have to mandatorily report, you might at some point decide that you wish to make a report. Again, this is still a slide from the driver safety course, but if there's immediate risk to driving and the person ignores you, then you do need to consider whether you report that. If the threat to the community is immediate, for instance, someone's intoxicated in their presentation, you ask them to wait around to be rebreathalyzed, get someone to call them to pick them up, but they leave and drive, then you may want to consider reporting that to the police. The second example there is possibly something I wouldn't necessarily do. If there's no immediate risk, then I'm not sure if calling the police at that point through the police assistance line is something I would do if the immediate risk to the public wasn't current. The way I would approach that is normally to think, okay, is this person fit to hold a license longer term, and hence is there an RMS notification that needs to happen? So there may be situations where it would be appropriate, but I'm happy to have people jump in and tell me what they think. So considerations have to include the medications and the combinations of medications. And so that includes how they might affect sedation, but also how they might affect disinhibition and risk-taking behaviours, and also drug interactions. So whether it's pharmacokinetic, where one drug alters the blood level of another, or whether it's pharmacodynamic, where there may be additive effects from, for instance, with sedation. And with opiate agonist treatment, before we move on to assessment more broadly, there are phases in treatment where it's recommended people may not be fit to drive. So induction, significant changes in dose, or if there's significant changes in other substance use, then it's important to be advising people about whether they should be driving or not. On a stable dose of opiate agonist treatment, then there isn't evidence that there's an increased risk of accident or injury. So it is perfectly appropriate if there's other medical and psychological conditions that are all stable, then people can drive on opiate agonist treatment. So there's some of the other things which we may come to in a minute when we're talking more broadly, but we need to consider things like sleep and medications that may be used for that, but also other things like epilepsy, seizures, and other significant things on cognition, heart disease, respiratory disease, diabetes, etc. And because often there's more than one condition. And so disclosing. So our obligation is that we need to disclose the risk of the medical condition or medication or substance use on the driving ability to the patient. So we need to be explaining that to the patient. For long-term conditions, we should encourage them to inform the RMS. If we think there's an increased risk, or we think someone's not following our instructions, or they're continuing to drive and despite being informed they're not fit to drive, then we have the scope to inform the authorities ourselves. And I guess we have to make a decision from the interest of this community and for the patient themselves, whether that overrides the confidentiality of the patient. And obviously the documentation in the records is important. And we are protected from reporting. So if we report in good faith to the local authority, the RMS in the New South Wales, then we're protected from civil or criminal liability in either doing a test examination or informing that licensing authority of findings, if that's done in good faith. So I think there are legal definitions of what in good faith is, but my colloquial interpretation is if we're basing our decision on our history, examination and clinical interaction with the patient, we've discussed it with them and documented it, then in good faith, we can make a notification. If we don't have evidence to back that up, then that may be problematic. Okay, so is there any questions from that perspective before I move on to more specific aspects of assessment?
I don't know if you can see Bronwyn Hudson's question. How does a health practitioner inform RMS if a person's unfit to drive? I guess Bronwyn's asking about the practicalities of that.
Yep. So there is, in the Ausroads guidelines, there's a medical notification form in the back. There's probably a medical notification form on the RMS website, but it is in the back of the Ausroads guidelines. You can download the guidelines for free on the RMS website or just by Googling Ausroads guidelines. So there's a form. It's pretty straightforward. I think it's 1.5 pages or something. And you can then email that or fax it or whatever other electronic ways you can lodge forms these days to the RMS.
So Dan's just posted their link in the chat. I'd also just make a comment here additionally to documenting and doing everything that you've said there. I've personally found it very helpful to get a second opinion from a colleague when I'm going to do something as dramatic as notifying the authorities. It gives me more confidence, and I think it's good to document that you've done that. It's not this that we've just done something cavalier.
Yeah, no, I think that's correct, and I think that's a good practice in lots of things that we come across where having, and that's the whole reason we have clinical review and case review, so we can discuss these things that come up, and then documenting those discussions is important. And whenever you may be doing something like notifying something like this, I mean, notifying APRA is another situation where I would strongly encourage that that's always discussed with colleagues or members of the team to be sure all the aspects of notification and things are considered. All right, well, I'll move on if there's no other questions. I can't see I don't want to touch the screen in case I wreck it, Richard, so I can't see any questions. So just jump in if there's something. There's
no more posted just at the moment.
Okay. All right, so so this little excerpt is from the Ausroads guidelines. So those are people who may not be familiar with it. It's quite a reasonably good document. It's not without its problems in using it, but it does give various sections or guidance for health conditions. So there's cardiovascular, there's respiratory, there's sleep disorders, there's mental health, there's diabetes, endocrinology, there's seizure disorders, epilepsy, and there's substance use and a few others. So under substance use, there's guidance around whether somebody can have an unconditional license or a conditional license, or whether they're unfit to drive. And so the things to consider are those three main things: the substance use history, their response to treatment, and their level of insight. Interestingly, and this is a contentious issue, or at least I think it is, that if someone has an alcohol or substance use disorder, in whichever way we might diagnose that, whether that be DSM or ICD, or they're not fit to have an unconditional license. So technically, everybody that comes to treatment for a substance use disorder technically can't have an unconditional license. Now, obviously, with engagement in treatment and trying to primarily provide a treatment service for patients, we're not going to be notifying everybody to the RMS, at least I'm not. And we all know that there's a large range of patients who, if we use alcohol for an example, who never drink and drive. They might have quite a significant alcohol use disorder, but you can be reasonably confident that they don't drink and drive. They may just drink in the evening, etc., etc. Obviously, there might be times when they may be at risk, but likewise, people with drug use disorders aren't necessarily reckless in their decisions around driving. So how I tend to approach things initially is, why is the patient there? If they're there for help and treatment, then that's the focus. But then things might crop up that might make us think more about whether that particular person should be driving or not. So there's private and commercial standards in the Austroad guidelines. And so for a conditional license, people need to be, in their terms, involved in a treatment program and been in remission for at least a month, remission being defined at the bottom, as well as not having cognitive impairment that would be relevant to driving, and an absence of end organ effects, peripheral neuropathy, those sorts of things that might impact driving. So that's fairly broad, and it's often those latter two things that are problematic in terms of, how do we really know if someone's not got a cognitive impairment? Are we going to do neurocognitive testing on every single patient? So yeah, it can be a challenging decision sometimes. Commercial standards are a little stricter in that the time frame is 3 months, and that there may be a need for an appropriate specialist to be involved in that assessment as well. And obviously, if you've got people driving trucks and buses and public passenger vehicles, then you want to be sure that those people are safe to do so. Okay. I might just go back one slide again. So those in the Austroad guidelines, if anyone's seen them, there is a summary table which summarizes those standards. And it is often, for some people, particularly, I think someone made a comment earlier that patients can present thinking it's just a sign-off thing. It's just tick a box, fill out my form. Thanks very much. I'll be out the door in 15 minutes. And they can be very unhappy with the process. And so providing that table that clearly sets out what's required moves us a step away from being the people that have created this system, even though we are the people who might be involved in deciding whether or not someone is well or fit to drive. Oh, I'm going the wrong way, sorry. There we go. So we can talk more about these subsets if you like. So I've divided it into alcohol or other drug use, specifically illicit drug use. So how I approach it is, I talk to the patient and get their history, and it's amazing what some patients will tell you. So that it does include obviously things like medications, their alcohol and drug use history, their history of treatment for drug use disorders and other things, their comorbidities. So that's really important. And as with anything, if you're going to get to the bottom of the main aspects of someone's health, talking to them about it is the first step. There are various sources of corroborative information that might be useful. So has a referral come from the GP? What information do we know about that? Are we going to contact the GP? In various LHDs, you may be able to access the databases for presentations to emergency departments or to other health services within the LHD. We can in Hunter, New England. So seeing whether people have presented and what for is very useful. Corroborative information from the RMS is variable, and I know Paul and I have had discussions before about whether or not the driving record can be obtained, because that can be a useful thing if somebody's, had repeated drink driving charges or other aspects to do with their driving record. But my understanding, and again, people can correct me if I'm wrong, is it's not available to us. So unless a patient crops up with it, it's not something we can get hold of. And then you've got obviously examinations. So how's the person presenting then and there? In the clinic I work in, I can breathalyze people, and I can obviously do an assess withdrawal. I can examine for end organ damage. And obviously I've got to consider cognition and mental health. And so generally, I don't formally test unless I've got some thought that there's some problem, and then I may do some screening cognitive things. And if I think there's a more substantial problem, I may get more formal cognitive assessment. And then there's the biochemical monitoring. And so as we all know, with alcohol, GGT, ALT, AST factors, changes in full blood count, MCV, MCH, and then carbohydrate deficient transferrin. So it's not that any one of those is the most important, but it's how you put all that information together to then decide, okay, this person does seem to be well, they seem to have stopped drinking. I know they've seen this person, that person. Their blood tests tend to indicate that. Their couple of presentations to me tend to be consistent. And so I may then be comfortable with signing the form. If something crops up in that process, then I might be asking for more testing. I might want to get cognitive testing. I may want one of the comorbidities to be assessed by somebody. But the other important thing in the specialist fitness to drive is I'm commenting on their drug and alcohol fitness to drive. And if something else has cropped up, I'll make a note to say if I think something else needs to be assessed. So if they need to see their endocrinologist, or if they need to have an occupational driving assessment, or if they need to have cognitive testing, then I'll make that comment. But I always tell the patient that I'm doing that. Do people want to comment on alcohol before I go on to? I can just click to CDT. The next slide is CDT. So I don't know whether people know carbohydrate deficient transferrin, serum protein becomes elevated with heavier alcohol consumption. Nominally, it's reported as if you drink 50 to 60 grams daily for more than 2 weeks, it'll go up. It's specific, but not particularly sensitive. In women, it's not as reliable. In liver disease and obesity, so it's not the be-all and end-all of biomarkers. A pattern of results is sometimes more helpful and interpretable than an isolated result. So if someone was drinking heavily and it's high, and then they're abstinent and it's low, then it can be a useful thing to see the change in result rather than the raw number. I have had patients where there's been quite high. So normal is generally somewhere between 1.8 and 2.2%, depending on the lab, so less than 2%. I've had patients where when they're actively drinking, it's 5, 6, 7%. And when they've stopped drinking and abstinent, it might be 2.5 or to 3, but not necessarily in the normal range. So the change is significant sometimes rather than the raw number. And you need to interpret the CDT in conjunction with other things that I mentioned previously. I don't tend to use CDT at all if, from a treatment perspective, I don't see that it's useful as a tool to be proving that someone is or isn't drinking. And usually if someone is continuing to drink in a problematic way, then it becomes much more obvious in other forms. But it sometimes is useful when you're putting it together with everything else, when you've got some sort of monitoring situation that you're involved in. There's no Medicare rebate for it, and it costs $100 or more depending on the lab. I mentioned on the previous slide ethyl glucuronide as being another biomarker. It's present in the urine as an alcohol metabolite. Again, it can be problematic to interpret. It stays in the urine for up to 80 hours. So what does it mean? If someone's drinking a small amount of alcohol and not problematically, then you're still going to detect it. So it's not really useful from that perspective. And if you want to be proving that someone is definitely not drinking, then you've got to do it at least 2 or 3 times a week, urine tests. So it's, in this situation, I don't see it as particularly a practical test. And
Craig, we might remark that DCJ are quite keen on doing hair tests, including
yeah. So I guess and I think you might have mentioned that there was some recommendation in that article too about hair follicle testing. In fitness to drive, there are going to be some people who have gotten into trouble for whatever reason, and they may be drinking at a low level successfully. They may not be our treatment cohort, but there are some people out there that may be drinking at a low level successfully. And so hair follicle testing is going to detect use. So it's useful if you want to show that someone is being abstinent, but that's more from a long-term treatment perspective or long-term treatment goal rather than in this circumstance. So do
you think we might ask Kate to comment at this point? Biomarkers is one of your things, and at RPA, the phosphatidyl ethanol is being tested, but for a special indication, I believe.
Yeah, sure.
Look, I don't know if I've got much more to say. I very much agree with what Craig's been saying. They're not the be all and end all, but every now and then when something doesn't add up and the pieces of the puzzle don't fit together, they can help you make sense of it. So and the phosphatidylethanol, I don't have much to do with it, but I think like the ETG, it's just got a fairly short window. I gather from Paul that the height of the PEth, the phosphatidylethanol, can give you an indication of how much they're drinking. But again, that's not telling you whether they're separating their drinking from their driving, which is, that's a tricky one. And I don't know, Craig, if you can comment to what extent in this driver assessment, are we just assessing the drinking or are we assessing separation from driving? I talk as one who's rarely had to do one of these assessments.
So there'll be a few examples in a minute where that'll probably come up as to how I try to negotiate my way through that, because there's obviously some people who they can't separate the two, so they have to be not drinking. But then there's others that you may be just looking at that you're hoping that all the indicators are that they're not drinking excessively on a regular basis, and hence their ability to make appropriate decisions are, at least at that point in the assessment, you're satisfied that they can make that separation. The thing like the driving record is one thing that is useful in that, because once people have had more than one DUI, they're likely to keep drinking and driving, or either they don't understand the significance of the alcohol use and metabolism and timeframes and those sorts of things, or their decision-making dissolves when they drink. So they make bad decisions even though they may not plan to drive when they're sober. So yeah, it's a tricky little pathway.
We had a question there from Jorg, which we hopefully answered just what is CDT. I just add that transferrin normally has some side chains, I think usually 5 or 6 sialic acid side chains, and the formation of those side chains is diminished by alcohol, and the destruction of the side chains is promoted by alcohol. And so if you get more than a certain percentage of these transferrin molecules that have only got 1 or 2 side chains, that's what's being measured, and yeah, that's the mechanism by which alcohol is causing the effect.
Yeah, and transferrin has a role in the iron metabolism and moving things into cells and things. And the alcohol cleaves off those carbohydrate side chains, and so you get a different different format.
So just on that point, the phosphatidyl ethanol is used, I think, mostly in assessment of patients who are or potentially on a transplant list, liver transplant list. So, they really want abstinence there. This is not a matter of working out whether somebody's drinking a controlled amount or not. They have to be abstinent. So it's quite a severe test and useful in that context.
Yeah, and so some of these tests are going to be useful if you want to be monitoring abstinence. And so there may be some other monitoring forms, like with APRA, whereby they want to know that someone is abstinent because their alcohol use disorder was severe and they're a neurosurgeon and they want to know that they're not drinking anymore. So biomarkers have a role in that in those settings, but here I don't personally think they're as useful, except in certain situations to add to all the other information. Okay, so in terms of drug use, in some ways I find illicit drug use much simpler than alcohol, because you're not allowed to drive with illicit drugs in your system. And if you've been using drugs regularly or have a substance use disorder, then in order to be fit to drive, you have to show that the person's been able to change that behaviour and stop their drug use and maintain that stability for 1 month or 3 months. So the biochemical monitoring that goes with every other part that we've already discussed in terms of urine drug screens is something that I would do, and I do them regularly, typically weekly for a month or up to 3 months if it's a commercial drive, a commercial license. And so if we're talking about cannabis, or if we're talking about stimulants, or if we're talking about other substance use disorder, even prescribed medications which they were supposed to have reduced and ceased or were problematic, then the urines need to be negative. So I find that a simpler process, particularly with illicit drugs, because if someone's not able to stop for a period of time for an assessment and maintain that, then you can't really fulfill the criteria of the guidelines to say that someone is in remission for a month or 3 months. Other people might disagree, but that's how I approach it. With a commercial license, I do the urines pretty regularly over a 3-month time frame, because you've got people driving trucks and buses and various other things, and most patients find that approach perfectly acceptable because they know they're not supposed to drive with those drugs in their system. You do get people that don't think their cannabis use is a problem, and that they don't want to stop completely, in which case, if they can't fulfill the full assessment, then I won't sign the form. So that's the end of the actual presentation bit, and I've got some cases. We're already at 8:15. Do you want me just to run into the cases, Richard?
I think so, but there are just a couple of questions there. So whether most people who do see a private addiction specialist do get their form done in the first session, or is it usually multiple sessions before it's done? Any idea?
So we have an approach that if someone, currently we only do these assessments now for patients where we've done it before, so that there's continuity of care, patients who are in treatment with us, or patients where the system, our health system that I'm immediately connected with, has made a notification. So for instance, if there's been a notification from the Mater Hospital ED or John Hunter ED, the Hunter New England immediate medical environment, we'll consider doing those medical assessments, because the medical fraternity, if you like, has notified. That's when we do them now. We try to resist doing them for just straight out referrals, fitness to drive, whether it's not engaged in treatment or anything else. So we try not to do that. However, when a new patient is being referred, they're told it will be more than one appointment, and there may be a need for communication with other treating teams or doctors, and there may be a need for blood or urine tests. So that's a standard 3 things that get explained to people when we're booking in, so that they know what to expect.
Now, Craig, we also had the question what the standard RDT tests, and Dan's typed the answer: ecstasy, so MDMA, cannabis, cocaine, and methamphetamine, notably not opiates, because that would be opening a can of worms, but of course it allows heroin through entirely. And then Bridget's question, which was...
Sorry, just before we go on that, it's also not opiates and not benzodiazepines. And I believe the driving evidence is that opiates and benzodiazepines as drug classes are more implicated in driving problems than the other drugs might be. Yeah,
absolutely. And I think it would be a brave politician who passed a law that would have a lot of elderly middle-class people pulled over for their benzodiazepines and their prescription opioids. That would be, that would be politically suicidal. The next question was, what about prescribed medicinal cannabis, so CBD, THC, in terms of the drug testing and legality?
So you can't drive if you've got THC in your system. So if you're prescribed a medicinal cannabinoid medicine that contains THC, then you can't drive when THC is in your system. So if you're using that substance on a daily basis, then my understanding is that the prescribers, the cannabinoid medicine authorized prescribers, should be explaining to their patients that they can't drive.
Yes.
I have asked that question to a lot of patients who have come on cannabinoid medicine, and I'd probably say at least half the time they say, yes, I was told that. So there are definitely people prescribing it who do tell their patients that. Whether or not the patient's paying any attention to it, that's a different matter.
Kate's put a question there, noting that urine drug screens can stay positive for cannabis for up to 3 months after daily heavy use after they stop. In that case, would falling quantitative levels of metabolites in urine be useful or required to prove cessation? How do you handle that?
So we do send our urines to FAS, Forensic Analytical Scientific Services in Sydney, and they will give levels, but I only use the levels to determine that it's dropping, and I still keep going until there's a negative and then a couple of negatives. So if I've seen that it's dropped and then there's 2 negative urines and it's a private license and it's clear that they've stopped their use, then I might not insist on 4 negative urines in a row. But if it's a commercial license, I'll be more specific that it's got to be maintained, the change, for that period of time. So yes, so in answer to that question, dropping levels can be useful, but at some point it's got to get to be none. It's got to get to be negative.
So Craig, how about we go with the first case at least? This is an interesting one.
Yeah, so these are all, we don't have to talk too long about them all, but they're all real people. This is a generic thing, but it happens all the time. Alcohol withdrawal seizure, presenting to ED, has a significant alcohol use history. This is a first seizure. There's no previous alcohol or other drug treatment. There's no other drug use, and there's no physical comorbidity. So what do we have to do? What do we have to tell the patient?
So Craig, I don't think we should torture our registrars by asking them to put up their hands.
All right. Okay. Do you want me to just...
Okay, shall I have a go? What investigations, any first seizure, the person's going to get a cerebral CT. They don't always get an EEG before they leave the emergency department. You can't assume that a seizure like this is an alcohol withdrawal seizure, and it's a bit too early to determine that, even if it's likely on the history, if there doesn't appear to be any other likely cause. And we generally advise a person not to drive until they've had clearance from a neurologist, and that will involve an EEG.
Yeah. So in summary, I'd probably agree with all of that. So basically, yeah, they need some sort of imaging of their brain. Some neurologists will say there needs to be an MRI, but CT is often where it starts. They need an EEG, and if the rest of the state is like Hunter, New England, you're lucky to get an EEG within 6 months if you're an outpatient. Treatment-wise, I'm referring there to the alcohol use history and what treatments they might need to undertake in order to treat their alcohol use disorder. And if you've had a seizure, you can't drive for 6 months. But you then can drive with a specialist sign-off. If you don't have a specialist sign-off, you can't drive for 12 months. So it requires a specialist. If it's an alcohol use disorder seizure, isolated single episode seizure with a reversible cause, and again, that phrasing comes from the Osroad guidelines under the epilepsy seizure section. So single episode seizure with a reversible cause, if you reverse that cause, the person's not drinking, hence they're not at risk of the alcohol withdrawal seizure, then that sign-off can be from addiction medicine if all their imaging is normal, and including their EEG, and if it's not, then a neurologist is the process that I would follow. So it's 6 months, but you have to have a specialist so you can drive. And that's a big issue. It comes up quite often with not just alcohol seizures, anyone that's had a seizure, that they can't drive. All right, we'll move on quickly because it's getting late. Weekend cannabis use in a patient with schizophrenia. The level of use is important. They're using just a couple of cones on the weekend, but as Kate's already pointed out, that may be present in their system for much longer or all the time. They're on antipsychotics and pregabalin. There's no other drug use apart from the cannabis. So that's you've got a vulnerable person who needs to be on medications that may affect their cognition, may also affect their level of sedation, and then you've got cannabis on top of it, but it may be the cannabis that they've been referred on for because it's been detected somewhere along the line. So, following the process, it would be talking about, okay, can they stop the cannabis and can you get negative urines? But it's also about, well, are there factors to do with sedation? Are there factors to do with needing a psychiatrist to say they're fit to drive? Are there factors to do with cognition that need to be assessed as well? Weekend stimulant use in a person applying for a disability parking permit. This is real. Like, I've had a number of patients be referred where they've applied for a disability parking permit and their GP's filled out the form. They've ticked the drug use box, see a specialist. They come to see the specialist and then they realise that they're going to have to stop their drug use. So the issues there are they never really thought it was a problem, and they can be quite antagonistic. But you do have to consider all the other comorbidities. The other question there is, why were they applying for a disability parking permit, which implies they have some significant disability. So there may well need to be an assessment of some other comorbidity, not just the fact that they use stimulants. So that scenario has happened several times when people are very annoyed that the applying for a permit has resulted in them having their driving restricted. So don't ever apply for a disability parking permit. Volunteer bus driver for aged care outings, drinks each evening, just a couple of glasses. He's 70, takes the aged care people out on their trips. He has the appropriate level of license to do so. That's potentially quite a tricky situation. So again, it's following the process with corroborative history examination, seeing them several times, getting some idea about whether this person does or doesn't understand the drinking. Is it just a couple of glasses? Are there chemical monitoring consistent with that scenario? And is there other things to do with their health that you've got to consider? So that's not that easy. And in that situation, because of the comorbidities, I said that the person couldn't have a commercial license. They weren't very happy. Person on long-term opioid agonist treatment presents with a deliberate self-poisoning episode of benzodiazepines and SSRIs. They're previously on 130 milligram stable dose for a long time, live on a farm 5 kilometres from town, no public transport, got to get the kids to school. So another scenario where there's a whole lot of other factors that may impact on fitness to drive. But again, it's the process, and it's like, very sorry, but in this circumstance right now, you have to reattain stability, and hence you can't drive. And until you can see that person and having established that they've reattained stability, then you're going to need to ask them to organise how they might otherwise get their children to school. So that could be a really tricky situation.
Would you distinguish between prescribed benzodiazepines and non-prescribed in this scenario?
From the deliberate self-poisoning perspective, no, because it's the use, because presumably they weren't prescribed at the dose to result in a intoxicated or overdose presentation. But ongoing prescribed benzodiazepines with opiate substitution treatment sometimes means you've got to consider, is this person, can they drive? So sometimes they're our own patients. We have them in front of us, and we have to sort of go, okay, well, currently you can't drive, and we have to tell them that, and or notify sometimes. So there's a lot to do with rapport in the whole opiate agonist treatment setting, and how you've set up the way you practice with patients over time, and how you may have dealt with situations of how you give them good and bad news. And so rather than it being sort of a knee-jerk reaction to just an isolated circumstance, it's built into the way you approach your consultations over time. But there's definitely cases where people will be on prescribed medications from other people, and they won't be fit to drive.
Craig, regarding sedation in that kind of population, we did a study of insomnia and daytime sleepiness. The daytime sleepiness using the Epworth sleepiness scale in people receiving buprenorphine and methadone treatment. Also, people using illicit drugs, including opiates, but not on treatment. And then a reference group of normal, healthy people, convenient sample. The Epworth score greater than 10 signifies significant daytime sleepiness, and that was found in some 14% of people on buprenorphine and 22% of people on methadone. If you go to the score of the cutoff of 15, which is really quite marked daytime sleepiness, buprenorphine 4.4% of those patients, methadone 6%. So just a reminder that that needs to be considered, and the Epworth sleepiness scale is actually a simple tool you can use for that. Happy to share that if anybody wants.
Thanks, Richard. So there's just 2 more scenarios just to finish off, and then happy to answer any questions. So this is again a real patient who had actually been referred by a drug and alcohol counsellor because he'd gone to talk about his methamphetamine use, and he was had a heavy combination license. He drove semi-trailers up and down the M1. He had insulin-dependent diabetes, type 1, for 19 years. He described himself as immersed in the drug culture, which sort of translated to possibly dealing. And after the initial assessment, when we did a set of bloods as an outpatient, pathology called and said his random BGL was 30. So I might ask people somebody to sort of go how they might start to disentangle this situation.
Well, I mean, he's admitted using the drugs, hopefully you get some idea of the frequency, but it would seem to me that this person would need to provide clear urine tests, and not just one, over a period of time for you to be able to declare, they'd have to aim at abstinence and demonstrate it. And then, of course, there's a whole issue around the glucose level or diabetes control. That would need assessment on its own merits by an endocrinologist, and it may well be that his drug use is part of the poor control of the diabetes.
Yeah. So again, I try to think of it as having a process. So immediately at that point, one, you need to contact him and deal with the sugar level, which he was a bit blasé about at the start. It's fine, I'll just give myself some more insulin, it's okay. So there's that whole endocrinological control side of things and review side of things. He's not fit to drive a semi-trailer at this point in time. He's probably not fit to drive at all. And that was explained to him. It was a little tricky because he'd voluntarily approached assistance to deal with his methamphetamine use, and all of a sudden he's having conversations about his livelihood and being able to provide for his himself and his children, who he didn't have access to at the time. So yeah, complicated process, and he initially was really resistive, but we tried to separate the treatment side with another service to deal with his methamphetamine use and assist him, and we dealt with the health side, us with the driving and the urine samples for methamphetamines, and getting his endocrinology review as well. And he actually, completely changed and ended up currently 2 years since he's used any stimulants and back driving, and it's quite well. So, but complicated situation. And the last one, alcohol use disorder, severe, but the person had stopped, had a stroke history, was referred regarding alcohol and fitness to drive. He was abstinent, his abstinence was clear from engagement in treatment over the past 2 months and other things. It was clear he wasn't drinking. That wasn't an issue anymore, at least in the last couple of months. His CVA was quite a number of years ago. He was in a wheelchair in the waiting room, but he could walk. He got up and shuffled into the console with left-sided motor dysfunction and a decreased range of neck movement. So my immediate thoughts there, having checked all the alcohol side of things and made sure that was consistent with not drinking, was that the person in front of me, I wasn't convinced could drive a motor vehicle, could not physically do the things required to drive a motor vehicle. So I guess it's important to just remember that you don't have to make the decisions yourself. If you've got something that you think needs more assessment, then you can refer on for that. And in this case, he said he'd been assessed previously and cleared to drive from his motor perspective, but I requested that he have an occupational driving assessment about whether he could physically perform the tasks required to drive a car, and to have a neurologist say that he had the cognitive function to drive a car. So whilst the alcohol side of things was quite clear early on that he was quite adamant he didn't want to drink, he'd stopped and was engaged in treatment and doing well, that wasn't the thing that was going to stop him driving.
Thanks, Craig, for the presentation. Great presentation, and those cases are really giving a really good flavour of a systematic approach, as you said, that we can take in those situations. Very helpful. I just note one last question here as we've gone over time, and almost everybody's still with us. What's the advice on Lyrica use, particularly?
Gee, that's a whole nother session, Richard. Look, there's lots of prescribing of Lyrica, there's lots of overuse of Lyrica. I guess it relates to any other sedative medication. You've got to try and interpret whether or not the person is affected by their medication in the short term and in the longer term, and whether it's prescribed with other medications, and then have those discussions with the patient. That's the first thing. It's a good time to mention SafeScript New South Wales for anyone that may not be aware of it, and being able to look up medications now to see people's script history and what medications may be prescribed. There's definitely a motivator factor in driving for people to change their medication use. And so that's something to also consider, particularly where we often see a whole lot of inappropriate prescribing, or prescribing that over time from different people has added up. And then when you look back, it's easy to say it's inappropriate or out of control or excessive.
Great. Well, I think we'll call that an evening. Thanks again, Craig and Kate, and everybody who participated in our audience of still 73 people signed on from the maximum of 81. It's really terrific. Thanks, Dan, for organising.